Hi guys, welcome to Mastermed Academy. If you are new to my channel, please hit the subscribe button and press the bell icon to receive future updates on our new and upcoming awesome videos. And don't forget to follow us on Instagram. Today we're going to be talking about achalasia of esophagus. Now this is the picture of normal anatomy of esophagus, and here I would like you guys to just know two things: that we have an upper esophageal sphincter UES and we have a lower esophageal sphincter, and in achalasia we have a problem with the lower esophageal sphincter. Now what is achalasia? Now achalasia is basically an esophageal motility disorder, and it involves two components. One, there is a smooth muscle problem of the esophageal wall, and second is the problem with lower esophageal sphincter. So only two things to remember here. Now when the smooth muscle layer of the esophagus is not working, do you think there will be peristalsis? No. So that's why in this disease we have a lack of peristalsis. Whereas in lower esophageal sphincter, when this is not working, we will have a lot of pressure because of the increased LES tone. Also, we have the inability of the lower esophageal sphincter to relax. Now, because of lack of peristalsis, it will be very hard to push the food to the stomach, right? Because there is no peristalsis. Whereas when you have LES problem, it will be very hard to make the food pass through the sphincter to the stomach. So now let's talk about the general organization of gastrointestinal wall. We need to know the components of the GI tract wall. Okay, so let's just get on with it. Let's imagine that this is a GI tract, and the blue layer is the mucosal layer, the dark green layer is the submucosal layer, the yellow is called the muscularis propria, and the last layer is the serosa or adventitia. Now we need to know exactly what are the components in mucosa, submucosa, muscularis propria, and so on. The first layer in mucosa is the epithelium, the second is the lamina propria, and the third is muscularis mucosa. The submucosal layer is rich in plexus. Now plexus is a collection of nerves, and the plexus that is present in submucosa is the Meissner's plexus. You can also call the submucosal plexus. We have two muscle layers in muscularis propria. We have a circularis muscle here, we have a longitudinal muscle, and in between them we have another plexus, and this plexus is called Auerbach's plexus. More commonly it's called the myenteric plexus, and it is this plexus which is damaged in achalasia. So because of damage to Auerbach's plexus, we have achalasia. Now this is the same picture what I just drew in the previous slide, and exactly the same layers of the GI tract that has been shown in this picture, and you guys can take a minute to look at this picture and understand, because it's really important to know the disease. Now let's talk about the pathogenesis of achalasia. In achalasia, there is a damage to the ganglionic cells present in the myenteric plexus or the Auerbach's plexus. Now what are the types of achalasia? Now depending on the cause of achalasia, we have a primary achalasia and we have secondary achalasia. Now the cause of primary achalasia is basically idiopathic, so we don't know the cause. While in secondary achalasia, the cause is a malignancy like squamous cell carcinoma, and more commonly it's Chagas disease, which is caused by Treponema cruzi. Now let's talk about the symptoms of achalasia. Now the most common symptom is dysphagia. Dysphagia means difficulty in swallowing, and in achalasia we have difficulty in swallowing both solid and liquid food. Now the next is regurgitation of undigested food, and patients also complain of bad breath. We can also call it putrid breath. And the next symptom is chest pain behind the sternum, and the last is weight loss. Now how to diagnose achalasia? There are two ways to diagnose achalasia. One is using barium swallow study. Second is the method of esophageal manometry. Now in barium swallow, we basically ask the patient to swallow the contrast, and using continuous fluoroscopy we determine the esophagus and its nature. Now because of increased LES tone and narrowed gastroesophageal junction, we have a characteristic classic radiological sign called the bird's beak sign. Now I'll show you a picture in a minute how it looks. The second is the method of esophageal manometry. Manometry is basically measuring the pressure. So we basically put a probe in the patient's mouth and we ask the patient to swallow, and we measure the pressure varying pressures in the esophageal wall. Now this is the barium swallow study, and you can clearly see that the patient is swallowing his own saliva, and the saliva is traveling through the esophagus, and there is the classic bird's beak sign. Now this is another picture showing you exactly what's the bird's beak deformity. So let's talk about the treatment of achalasia. The best treatment is surgery, of course, but also we have medications to alleviate the symptoms. The first class of drugs are calcium channel blockers, and the most commonly used drug is nifedipine. The second is the nitrates, and the drugs that are commonly used are nitroglycerin and isosorbide dinitrate. The patients complain most commonly headaches as a side effect of nitrates. So you have to remember the side effect is headache of using nitrates. Now the second type of treatment is a balloon dilation, also called the pneumatic dilation. So let's imagine that this is a stomach here, and we're just going to put a balloon near the GEJ junction, and we're going to do a forceful inflation. Now the inflation of the balloon leads to the stretching of the smooth muscles of the esophageal wall, and we hope to restore the esophageal function from this pneumatic dilation. The third type is the surgery, and the Heller's myotomy is the most commonly used procedure. Now this is a cartoon that shows the pneumatic dilation and how we do it. Now in the first part of the drawing, we see that we actually put the pneumatic dilator through the esophagus, right, till we reach the gastroesophageal junction. And once we reach that junction, we insert the balloon and we start to inflate it. So once we inflate the balloon completely, as you can see in the third picture here, the balloon is completely inflated, and that leads to relaxation of the smooth muscles of the esophagus. So once the smooth muscles of the esophagus are relaxed, we basically restore the flow of the food through the esophagus. So we no longer have the increased pressure that we saw in the esophageal manometry. So I hope you guys understood achalasia of esophagus. If you have any questions, please write your comments and I'll try to answer them as soon as possible. Thank you for your attention.